Good morning to everyone. I'm very glad to be here, and I enjoyed the presentation before, even if the audio was not good. But I felt a lot of point in common with what Charlene and the next presenter spoke about. I am a lactation consultant here in Italy, and I've been lucky to become part of this project, which is called AllatTiAmo, and that's the name is a play, is a game with words. AllatTiAmo means let's breastfeed, but it also means, but Ti amo means also I love you. So it's the mix of love and breastfeeding. Now, what is this problem? What is this project? It's all about cleft and breastfeeding. The big issue is, can cleft babies be breastfed? What we usually meet in is that mothers and families are told, no, they can't, give it up. And the project was born as an answer to this. So I'll go over the problem first and then how the project was born. So you all know, I suppose, what a cleft is. An oral cleft is a discontinuity in the oral structure. It can only concern the lip, or the lip and the gum, or the lip, the gum and the palate, or only the soft palate. Both. It can be unilateral, bilateral, and all these is important because different kind of cleft can affect breastfeeding in different ways. So the problem is that you all know that vacuum is the main mechanism of milk transfer in breastfeeding. It's not the only one, but it's the main one. And a cleft can partially or completely impair the ability to create vacuum in the mouth. Just one second, I have a technical problem. Okay, and how? Here you see how the cleft can impact the ability to create vacuum and why each kind of cleft is different. This is a transverse representation of the mouth while breastfeeding. You see the light pink on the left is the breast, underneath is the tongue, up the palate. This is a picture of normal breastfeeding. You know that the tongue elevates to block the breast and seal it against the palate to create a vacuum chamber in the mouth. And when the tongue goes down, oh yeah, you probably, did I share my camera? No, I didn't. I'm sorry, you were not looking at me, so I can move my arms and teach to you. Just one second. Here I am. Can you see me? Hello.
Yes, we can see you. Yes.
Okay, great. So I can move my arms and you can see. So this is the breast. The tongue will block the breast above against the palate and will go down to create a vacuum to suck milk into the mouth, and then he will push the milk backward to the swallowing. So what you need to create vacuum is a sealed chamber, but the cleft can create an unsealed chamber. So what you see here in the middle of the mouth is the critical, what I call the critical zone to create vacuum, because if the cleft is only concerning the lip here, can you see the mouse, I hope, the breast can seal instead of the lip. You will only have a slightly weaker seal, but the vacuum in the mouth will be still possible. And the tongue at the back of the mouth will seal with the soft palate. If the cleft is very tiny of the soft palate, you can still create a lot of vacuum. And so suction can be at least partially effective. Then when the tongue goes down, you may hear a sound like, and the vacuum may be released, and so you don't have a complete efficiency, but you can have some degree of efficiency. So depending on where the cleft is, only the lip, only a very tiny part of the soft palate, or if it goes farther inside the mouth and to the hard palate, you may have different degree of inefficiency and in some cases there is no ability to do the vacuum. So this can affect the ability to breastfeed. But then again, is it possible to breastfeed? And I say that the answer is yes, because some form of breastfeeding is always possible. Some infants with cleft can really breastfeed at the breast. Some will be able to do something. And here you know that exclusive breastfeeding is defined as feeding at the breast milk exclusively. But in the case of cleft, we have to embrace a wider meaning of breastfeeding, because breastfeeding is made of breast milk feeding, of feeding at the breast, whatever you feed. And well, the ideal would be at breast with breast milk. Some of the cleft children can, some cannot, but any combination of breast milk and breast can be considered breastfeeding, and therefore it must not be given up. How you reach it depends on a lot of things. And it depends, and you must have a realistic expectation depending on the situation, because as we said, different kind of clefts give different kind of feeding. And we were saying with the cleft of the lip, we can have a normal breastfeeding. You may have to change slightly the position. Here you see babies with cleft in the left part of the lip. And so even the first picture, you see that the baby is in a sort of rugby position. It's outside because putting the left side of the face towards the breast would increase the seal, improve the seal, and so it was easier. And even the other baby is doing the same to close the gap in the lip. But these babies could breastfeed very well, and they did breastfeed until very late. And the problem is that sometimes even with cleft of the lip, infants are separated from mothers and they are put in the NICU, and they may be fed with a nasogastric tube, which is absolutely an overshooting. You have other cases. The complete lip and palate can be much more challenging, and feeding at the breast is more difficult. There are reports of infants with complete lip and palate cleft breastfeeding at the breast. You are perhaps aware of a study from Thailand, where in a hospital they managed to teach the mothers to feed the baby at the breast by expressing milk and so on. What we see is that in these cases, it's very difficult that the mother can breastfeed at the breast. But nevertheless, they can at least partially feed at the breast with a supplementer, or they can feed breast milk, which is also very important for these babies and for any baby. Palate cleft and Pierre-Robin sequence babies are the most perhaps difficult. In the bottom right side of the screen, you see a baby with an angry face. This is a baby with Stickler syndrome and the Pierre-Robin sequence. And she had a very hard time feeding at the beginning of her life. And the mother did not find much of help around her. And she was one of the first person to set up the AllatTiAmo project. Because of her experience, she found that support was so important in her case. The problem with these babies is that they often also have breathing issues. and breathing is very important for feeding. If a baby has to choose one or the other, they choose breathing rather over feeding. It means that they they are too tired, they are exhausted, and they don't have enough time to feed because they have to breathe more than other children. It's more difficult for them. So they don't have time enough to eat. And sometimes, even with the best technique of facilitation, it becomes very, very difficult to feed this baby enough to achieve sufficient growth. And in these cases, you have to go to nasogastric feeding, and sometimes it really helps because it takes off the huge burden of make the baby growth out of down from the shoulder of the parents, and they start enjoying more their babies, and they can dedicate time to improve the skills of the child to feed and find the right technique so that in time oral feeding become more and more possible. And these are all babies that I know, of course. And you see that on the bottom left, you have this lady with the baby at the breast. She was a beautiful baby who didn't have much trouble breathing, so she was fed breast milk with bottle. At the beginning, she was able to go to the breast, and the mother did enjoy that enormously, even if the baby was not taking milk. And this is also so much important. Another very important aspect to consider how to choose what choice to do regarding feeding is the surgical prospect. In Italy, we have different centers with different chirurgical protocols. Where I work most, the protocol is to have to close the palate around 6 months or a little later, but usually well before 1 year. In other centers, they close the palate at 1 year, 18 months, and sometimes even later. Of course, for the mother to hold on the idea of breastfeeding for 6 months, hoping that after that she might have a normal relationship of breastfeeding is one thing. To wait until 18 months could be completely different. Not all mothers start knowing that a baby can be breastfed until 2 or 3 years. They may think that, well, if they don't breastfeed in the first 6 years, what's the meaning of it? Taking into account what is the prospect of surgical repair is also very important for the motivation of the mother to set reasonable objective. The baby you see here is had a bilateral cleft, complete cleft. Is the same baby you saw in the first picture, and the mother was told yes, after repair they can start breastfeeding, and she stick to it with the idea of breastfeeding, and she did manage. It was absolutely not an easy road, and I heard say once that, well, I think they forgot to tell me how difficult it was. It happened really in a small number of cases, but if they had remembered to tell me, perhaps I would not be here. So I think the baby went far beyond 2 years breastfeeding. Another issue is the available support. Support for feeding, support for caring for children, support for pumping. We know that having to pump, feed, and maybe attempt feeding at the breast, and then maybe you have also older children, and for sure you will have visits at hospitals and things like that. So it's not easy. You have a lot to do. So if the family has support share the burden of all this, they are more likely to hold on breastfeeding and investing in this. But if they are left alone and don't have much resources, it could become incredibly more difficult. And also, as we heard from the previous talk, if the expectation of those around these families are against breastfeeding, they may give up. When you are asked how many bottles and you're trying to breastfeed, it is terrible. If at the first difficulty you're said, but you can give up pumping, it's not that important, you may end up giving up, even if it's not what you want. So, because this world is so complicated, we have to prioritize, we have to set objectives which are achievable, and especially we have to choose this. We as helpers don't have to choose. We have to help the families to choose what is most important for them and reasonably achievable for them, depending on their priorities, preferences, and all the things that are around them. And we also have always to keep in mind sustainability. So if they start and at a certain point it's too much for them, we also need to support them in changing their objectives. So the key message here is that every baby deserves the opportunity to try and do their best with breastfeeding. And every family deserves the support to try to achieve their goals. What happens is that they do not always have this kind of support. Talking with families, we know that what the main problems are. Oh, I must say that in Italy, it's very important, and I find that in different countries, clefts are managed very differently. In Italy, infants with clefts, even if diagnosed before birth, are born in normal hospitals, not in cleft centers. Our cleft centers are specialized in surgery, and they are not specialized in caring for cleft babies from birth to surgery. So the babies are born in normal hospitals, and then the families get in touch with surgical centers, and they are followed mainly for the surgical part. But feeding is something that is dealt by the birth hospital, the pediatrician, and so on. So I think that these expose the families to a much lower level of expertise about clefts, because even if cleft is one of the most widespread common birth defect, it's not common enough that each hospitals develop specialized expertise on that, because they may see 1, 2, 3 a year, depending on how big the hospital is. So all this shows us that cleft infants are at a higher risk for separation at birth, and often they are at risk of interventions. They are put in the NICU, they have nasogastric tube inserted, even if it's not absolutely necessary. And therefore, we know that this increases the chance of problems of breastfeeding issues. And we know that any child is at risk of breastfeeding issues when the management at birth is not optimal. And these babies have a much higher risk of that. And there's a lack of support for specific feeding challenges. I've seen hospitals where, because they didn't have the frequent exposure to special bottles, they didn't even know how to assemble one. And so the baby could not feed because They were using the Medela special feeder, and they didn't insert the valve in the right way, or they didn't insert it at all. So the bottle was not working, and they thought it was the baby who could not feed. So the families needs support and information. And one other huge problem is that there's not enough support for establishing and maintaining breast milk production. The mother has to pump and has to start early with an appropriate pump, with flange of the right size. All this information are not often given to the mother. And it's not easy to maintain production if you don't use the hands-on technique. But the mother says that I started pumping, then after 2 weeks, 2 months, I lost my milk. And if you dig and ask what kind of pump they were using, what were the routines, they had no support to do that. So there are many things which are common to any breastfeeding families, but there are also very specific issues around this family. And one other thing is that in Italy, the lactation consultant is not usually present in cleft teams. So there's not the perspective of breastfeeding from the start. So the answer was this project, which put families and professionals together. The project came out of this association, ISME, which is an association of parents of cleft infants, because they were facing the same difficulties over and over again, and they were trying to help each other. Then we met and we discovered that we could help them. And so we started working together. I mean me and other lactation consultant, and that we discovered that there was a possibility to become stronger. So they created this project where they created a network of lactation consultant. They also did some specialized training for them. We had Catherine Watson-Jenna come to Italy for a 2 days course. Then we had Krista Herzog from Switzerland. And so everybody had some additional training over the normal knowledge you have as a lactation consultant. And the project gives to the families the service of in-person consultation from one of us, lactation consultant. You see that the map of Italy with the numbers are the numbers of lactation consultants in different regions. And you see that in some regions there are a lot, in some regions there are very few. There is a very uneven distribution of us. In some regions there is absolutely no one. And in that case, the project tried to support families through online consultation. And some of us can do that. It's not the same as being there in person, but it's better than nothing, because you can still give information, you can still look at what the child does, and give information to the family to deal better with the situations. So the families receive the consultations for free up to 6 hours, but they are renewable to more hours. Another thing that this project do is to have some of us into, at the moment, two of the biggest cleft centers, surgical center in Italy. One is Pisa and the other is Milano. We started first in Pisa, and then other colleagues were able to start in Milano. And in these centers, we can give prenatal information to families because they come when they are still pregnant. So we can talk to them about what they can expect, and give them the information to start in the best way possible. We see families with small children coming for the visit with the surgeon, so we can revise we can help them with feeding, we can give them information, and sometimes we really have very moving ways, opportunities, and it's really a huge opportunity. Then we see them even at surgery in their or later when they come for follow-up. So it's a moment where we see a lot of families. This is Chiara Totti, Paola Mazzinghi, and myself, who are the ones who rotate into the cleft center in Pisa. And these are Miriam Lelli, Silvia Colombini, and Katia Micheletti, who rotate in the Milano Cleft Center as my house. And another thing that the project does is education for maternity hospital staff. And this is a part which Chiara and I developed. We developed a 16 hours course over 2 days, directed at nurses, midwives, doctor, whomever wants to come, but directed at people who works with the newborn, how to feed them. And it has been an incredible experience, actually, because we are able to reach these persons. They are usually very open and very eager to share the knowledge. They may have a lot of expertise because they see a lot of babies, but they also see difficulties, and sharing our experience gives them often a different point of view, and it's extremely interesting. So we bring some key messages through a course which use different teaching tools. We have classes, we have exercise, we have brainstormings, we have practical activities. We teach through practical exercise. So it's usually very not boring and effective. So the message is that breastfeeding at the breast or with breast milk is important for cleft baby, even more than for any other baby. Well, for a healthy baby. Cleft babies may be able to breastfeed at the breast, so don't give up just because they have a cleft. Give them a chance. Another big issue is that cleft babies are generally able to feed per mouth without risk if appropriate facilitation and compensation are used. And this is something that we find very, very important, because in several hospitals we have found that the babies are not allowed to have anything per mouth. Even if they would be completely ready and willing to do that, there is resistance, and they start with a nasogastric tube, retarding all the imprinting of normal feeding. So all the normal obstacles of breastfeeding are there, and even more. And our objective should be to clear the way to everything, all the obstacles. And also that the other message is that family needs information and support to achieve their goals. So they have to be there for the family and to be able to give information and support. So the results of this is that, yes, of the project as a whole, we see improved breastfeeding outcomes and the family feel much supported. So of course, we don't have all families solve all issues, but and sometimes we find ourselves solving feeding issue with bottles and with artificial milk instead of breastfeeding with breast milk. But the same, that is also an important thing for families. And we are seeing changes in hospitals, small changes, but they're there, and we have incredible feedback from the people we work with in hospitals, because they really change their way of seeing breastfeeding, and they are more able to support families, and they are enthusiastic about it, and it's really beautiful. The picture you see here is a picture we took at the end of one of these courses, and you see the smiling face. It was at the end of the second day. We were all very, very tired, but the smile was there because a lot of things started to move from those courses, and there was excitement, expectation for the future. And the other thing that we achieve is that there is more attention to normal feeding and breastfeeding for cleft babies, and I must say for any baby, and that is extremely exciting. So normalization is something that we want to achieve, and I think that in many cases we reach it. So I think that this is more or less what I wanted to say. I have to thank the families that share their pictures and their stories with us. And for any more information you want, these are my contacts. You can reach out to me. ISMEL and the AllatTiAmo project are, of course, all in Italian, but Google Translate do wonders. So you can try to reach out, and thank you.